enviar el enlace, por favor? El link para que te pueda ver la agenda.
Es que lo busquen en el YouTube como similar.
Buenas tardes. Bienvenidos nuevamente. Vamos a tener la última sesión del día. Parece ser que va a ser una sesión un poco más corta, entonces seguramente se van a poder ir a su hotel un poco más temprano. Pero igual esperamos que hagan muchas preguntas al final y que se interesen por esta sesión. Como ponente invitada y una de las sesiones abiertas del diplomado y de las sesiones que más nos interesa que ustedes escuchen, tenemos a Kasia Malinowska, la cual viene directo de Nueva York. La sesión va a ser en inglés, hay traducción simultánea para quienes lo requieran, creo que ya todos los que necesitan tienen. Si alguien más necesita, por favor levanten la mano y les damos un aparatito de estos. Entonces voy a presentar a Kasia. Kasia Malinowska es la directora del Programa Global de Política de Drogas de Open Society Foundations, programa que promueve políticas de drogas basadas en derechos humanos, justicia social y salud pública. Kasia anteriormente lideró el Programa de Desarrollo de Políticas de Reducción de Daños, el cual apoyaba derechos humanos y de salud de consumidores de drogas. Antes de trabajar para Open Society Foundations, Kasia trabajó para el Programa de Desarrollo de las Naciones Unidas en Nueva York y en Varsovia, liderando reformas de política de VIH y drogas en Europa Central, Europa del Este y los países de la antigua Unión Soviética. Kasia publica regularmente acerca de políticas de drogas en temas relacionados con mujeres, justicia social, salud, derechos humanos, sociedad civil y gobernanza. Ha publicado en revistas como Lancet, The British Medical Journal y el International Journal of Drug Policy. Kasia hizo su tesis doctoral en VIH entre usuarios de drogas en Polonia, paradojas de una epidemia. Kasia ha coautoreado el primer programa de SIDA en Polonia, el cual ayudó a formular la política del Global Fund to Fight AIDS, tuberculosis y malaria. Kasia tiene una maestría en la Universidad de Pensilvania y un doctorado en salud pública en la Universidad de Columbia. Entonces, sin más por el momento, Kasia, you're welcome to come here.
Good afternoon, everyone. I know that you've been here listening and discussing for quite some time, and the room is a little dark. If you see your neighbor falling asleep, just not so there's no snoring. Otherwise, feel free to ask questions, to interrupt me. You have heard about me. I'll just add to it that I also am a parent of 2 kids, 14 and 22. And as you can imagine, drugs are high on our agenda. So not only is this my great professional interest, but also personal, as you can imagine. Now, you know a lot about me. I don't know a lot about you. So I'd like to spend maybe next 2 minutes asking you some questions, just so I get a sense of the room. And if you can just wave to me in response. So how many people are from Colombia? Great. How many people are from Bolivia? How many from Peru? How many from Mexico? Yeah. How many from Mexico City? How many people outside of Mexico City? Super. How many people are from Guatemala? Anywhere in Central America? Okay. How many people, any countries I missed? Brazil. Okay, so Argentina. Okay, Venezuela. United States. Brazil. Super. Okay, what else did I miss? Ecuador. Okay. I asked Peru. Okay. Now, how many people work in medical settings? Okay. How many of you consider yourselves academics? Okay. How many of you work for local or national government? Okay. How many of you are drug policy reform activists? Okay, super. Okay, great crowd. And how many are from Colombia?
We have journalists.
Oh, okay, journalists. Great. Okay. Super. Thank you so much. So I was asked to talk about public health and drug policy, and more precisely, how drug policy impacts public health. So this is what we are going to discuss for the next bit of time. And I guess, sometimes people ask me, like, why are drugs something that's of interest to me? How did I engage in drug work? And I have been working in the space of health for many years, HIV prevention, and from broad HIV, I started to work with drug use and HIV. And so what became very clear to me that drug policy is highly problematic in a way that it gets in the way of good public health. And what I find incredibly ironic is that if you look at various UN documents, where multiple states, 152 or something equally impressive, comes together and makes agreements in the international space around drugs, that those agreements are very often have a preamble of supporting public health. So when you look at UNGA's declaration from 1998, drug-free world, we can do it. And when you look at justification for that document, and for those people coming together, it is to protect public health. if you look at 3 UN conventions, big letters explaining how the international community's concern for well-being and health of their citizens is coming together to create a drugs regime. And because I am a public health professional, I got my PhD in public health, I feel particularly offended by the fact that all of those things that are happening across the globe that are not particularly positive are in fact happening with an excuse of public health or in the name of public health. So, many of you will have your own reasons for why you do what you do and why drugs are of interest to you. For me, in particular, it is because I feel that drug policy actually undermines and gets in the way of good public health. And that is what I want to spend a bit of time talking about, and also hearing from you about. So this is what it looks like in Russia. This is a person that is in the emergency room that came in because of drug-induced problems. After his health stabilized, law enforcement was called in. Now that, I'm sure all of you will agree, is not a way to deal with a health issue. And we see that connection between health and drug policy in many countries across the globe. Russia isn't the only one. If you look at China, Public Security Bureau very often gets names of people who are in treatment. When you look at Vietnam, again, you will have lists of people who are identified as drug using, going into security bureaus. That's why people have significant concerns when it comes to registering as a drug user, for example, in Uruguay, because they don't really want to be in any sort of register, which they fear may be shared with law enforcement. So that is not the case in Uruguay, just to be clear, but I really understand the discomfort that people have when it comes to the relationship of health and drugs. So I traveled to Urumqi, which is sort of off the beaten path in China, where the minority community of China, which mostly lives in Urumqi, is Muslim. And I traveled at the time where people were sort of very excited in the public health sphere because China introduced methadone treatment. Everyone knows what methadone is? Okay, methadone is a medication that is given to to people who are heavily opioid addicted. And basically what it does is prevents withdrawal and it lets them lead healthy lives. So China, in a very Chinese way, rolled out methadone treatment, which was a great success. They went from 0 programs to 1,200 within like 18 months. So in terms of rollout of services, it was obviously considered as a big success. And so in Urumqi, I sat and had a conversation with people who were drug using. And I asked, how many of you are planning to enroll in methadone program? None of them were. I asked why. And they said, why would I self-identify myself as a drug user if my name and my information could be shared with security? So I think this relationship of people who use drugs to security services is actually quite complex and difficult one. And it happens continuously. Not to pick on China, there is a study in Harlem in New York which shows quite high arrest rates around the methadone clinic. That's where cops situate themselves when they want to increase number of arrests. When safe injecting facility was opening up in Vancouver, people who are provided of those services really need to have a very concerted effort in terms of negotiating with law enforcement to make sure that police officers are not standing around the corner and arresting their clients. So all of those are examples of how criminal justice undermines public health. Aerial eradication. Those of you from Colombia will know well that this is a practice that has gone on in the country for many, many years. The effects, public health effects of that are many. Right? Chemicals sprayed from the sky can't be good for you. They can't be good for skin conditions, for water pollution. I mean, never mind the destruction of the crops. There's also a lot of other implications of aerial eradication. So when we start looking at criminal justice, and when we start looking at how criminal justice looks at drugs, what becomes actually quite clear is that there's very little reason that's being used in terms of how people are punished for various drug crimes as they are considered. So here are some examples from right here, a study done by WOLA that shows that in Ecuador, drug trafficking has a harsher sentence than murder. In Bolivia, maximum prison sentence for drug trafficking, 25 years, for murder, 20. Here in Mexico, drug trafficking, 25, murder, 24. So I think this question of, have we overused something that should be an exception in terms of response to a public health program, I think becomes quite clear when one looks at criminal justice issues. Now, many people will tell you that, okay, let's move people from criminal justice system into health. And, that's an interesting idea. Again, I'm a public health professional. In principle, that sounds fine. But very often what that means is this shift in outside of criminal justice into health means treatment. And very often, it is forced treatment. So I will often hear people saying, well, at least they're not in prison. But when you think about forced treatment, the question is that an alternative that we should be promoting? So I guess what I want to encourage you to think about is that when we shift people outside of the criminal justice system and into health, then we actually do a really thorough job interrogating whether those health interventions are appropriate ones. So again, I'll give you an example of Vietnam. Vietnam has not entirely involuntary treatment. Very often, very frustrated parents will bring their children, or a spouse may bring his or her partner. And so they, in principle, enter that system voluntarily. But once they're there, they can't get out. They cannot get out until a provider will say that they are now free of addiction. Who defines free of addiction? How is that being defined? What are the protocols that the country develops to be able to let professionals make that decision? Who knows? Many of you will know that drug treatment facilities are run by evangelicals, but former drug users themselves, by various sort of social service networks, where again, what is free addiction of addiction? How do we know whether a person is quote unquote cured? So in the Vietnamese situation, the problem becomes so acute that people are there sometimes 2, 3, 4 years. Because, they had a bad morning and they mouth back, they told their counselor to, buzz off. And that's it. They're not ready to go because they're not properly socially integrated. So, these are really significant questions to ask yourselves. And think about it, because I often hear drug policy reform folks saying, okay, let's just shift people into the health system, without sort of giving some thought to what that health system should look like. So someone who is an occasional user of whatever it is, whether it's heroin, whether it's cannabis, whether it's cocaine, occasional user does not require treatment. They're not dependent. And many of us will agree, okay, that's fine for cannabis users, but if someone is a heroin user, they should go into treatment. You can be an occasional user of heroin and not require treatment for a long time, and then decide to stop on your own. You know, just like many people who use alcohol, you know, heavy drinkers, who decide, wow, you know, my life has become too complicated because of booze. I'm just going to stop. And they don't need treatment. And then there are others that do need treatment, and they need treatment badly, and they don't want to go, right? So the spectrum of sort of services that are needed by people is really wide. Harm reduction. How many people know what harm reduction is? Many people, okay. So, you know, this is accepting people where they are today. This is accepting them where they are today and not forcing them into treatment. So, you know, just generally sort of a message that I would really want you to take away is that yes, health is better than criminal justice, undoubtedly, but only if it's appropriate health. Because if you're sending, you know, a 17-year-old occasional cannabis smoker to a 2-year rehabilitation center, probably not a good idea. And we've seen that happen, you know, that does happen. And another point, and I think I'm going to come back to it a little bit, but another point is, you know, health treatment industry is just like any other industry. There's insurance money involved. There are people's jobs on the line. There's salaries, right? So, you know, it becomes a little complicated when someone tells, you know, a very worried parent that we can take care of your child for 2 years for cannabis addiction. So again, keep your eyes very open. Keep on asking questions. And it's true that health is better than criminal justice, but only if it's appropriate health. Sometimes it may be counseling. Sometimes it may be a quick intervention. Sometimes it requires substitution treatment. So let's just keep our eyes very wide open about what is needed and required. So on to forced treatment. A couple of years ago, I think one our colleagues at OSF produced a report. No help, abuse as drug rehabilitation in Latin America and the Caribbean. That is downloadable on our OSF website. And so I would suggest that you do look at it, particularly if you're engaged in discussions about criminal justice versus health. So some points from that report. Not all drug use is problematic. If there's no addiction, there's no need for treatment. Does that sound true to you? Okay. The absence of prevention and care for both HIV and hepatitis C constitutes a major public health risk for people who are detained in forced treatment facilities. So again, you know, people get locked up 6 months, 8 months, 12 months at a time, and there's no treatment for really serious health conditions. You know, HIV epidemic or even hepatitis C, you know, throughout a year can advance quite rapidly. So the fact that there's no treatment for serious health conditions is an issue. And then quality of treatment among some providers is quite troubling. And again, this is an interesting group from a big part of the region, and so I'm sure you can tell me about the coercive and abusive services that are available in many of your countries. And we had a terrible, terrible, terrible news from Ecuador just recently. Diego was it 17 people? 18 people got burned to death in a treatment facility. So government really needs to take responsibility for the standards of those centers. And this is not the first such news that we hear from across the world. Actually, the first story that I followed was a treatment center for women in Russia, where again, somewhere close to 20 young women burned alive in a center where they couldn't escape because it was a crappy building with inappropriate support. The person that was taking care of them at night just left, got scared and left.
Just a question, these people were burned because it was an accident or just because they meant to burn these people?
Well, from what I understand, the fire was set sort of as a protest with an assumption that people will get out, right? But again, crappy facility, staff that was not responsive, property, and people burned. So any thoughts, any questions on that specific issue? You know, and just to be clear, I'm all for drug treatment for people who want it, need it, and in well-run institutions. Also, inpatient and outpatient. So not to belabor the point, but just to show you, this is a detention center. This is a treatment center in China. And you know what's really interesting is for many, many years, China was reporting people in those detention centers as in treatment centers. So if you were to look at World Drug Report that gets published every year and that shares national data from countries, all of those people right here, 1, 2, 3, 4, would be accounted for in a little table as people in drug treatment. And it actually took a significant push from advocates like many of like you who said that's not treatment. You know, let's use WHO standard of treatment, and if it's not met, then those folks shouldn't be counted as treatment. And so one by one, sort of countries that actually have forced treatment are now taking it out of the data. Also, interestingly, you look at many international organizations that are supporting drug treatment, and we found out some of those Chinese treatments were funded, you know, by other countries. Because who doesn't want to fund drug treatment? And there wasn't due diligence that was done, which actually has shown that these are detention centers. I think there was a moment when UNICEF was actually funding either in Cambodia or in Laos, really not knowing what they're funding, because they were funding drug treatment for young people, which really was the classic detention center.
I see in the pictures there's a lot of military personnel.
Yeah, it's actually, those centers are run by the Public Security Bureau in
That's what I
China.
wanted to ask. Is that common in these treatment
A lot of centers in Asia are run by Public Security Bureau. And it's actually interestingly a revenue stream for them. So then it becomes actually quite complicated to take it away from them, because they now feel like they own it and that they do a good job. And you know, when you have a conversation with them, as I had many opportunities to do, they will tell you that many people, most of the people that live here, live drug-free, that they're recovered. So what's another example of drug policy sort of going wrong? So when you look at the HIV epidemic across the world, you know, many of you I'm sure know, you know, HIV epidemic long, 30 years in the making, and many of you have heard about gay men in the United States and sub-Saharan Africa and so on and so on. And if I were to show you the curves the epidemic curves of those epidemics, you will see that they're relatively sort of slow. People were getting infected over time, but that those infection rate, that the curve is sort of, it goes up, but it's very slow. This is really stunning to epidemiologists, because HIV spreads very, very quickly once it enters drug injecting community. And it happens because, it's needle sharing, so it's a very sort of effective route of transmission. So communities that had no HIV, there are just some examples. In Edinburgh, over 40% of drug users got infected in such a short period of time. In Bangkok, same. In Myanmar, in Burma, over 60% injecting drug users infected within 7 months or something in one of the cities. Manipur and Yunnan in China, Ho Chi Minh City in Vietnam, and in Odessa. So again, all of this is likely to happen if there's no quality treatment, because why would people go to crappy treatment? And when there's no needle exchange and syringe exchange and methadone programs, and where law enforcement is very aggressive against drug users. Those three things come together. And it's logical that they come together, because if you have a very repressive government that is chasing drug users, where people are constantly in hiding, then you create a situation where providing services for people who are active is not a popular thing to do. Or people don't necessarily come because they're afraid. And drug treatment also becomes very punitive in that environment. Because, the assumption is that drug treatment should hurt. Because if you're a criminal, then why shouldn't it? Then sort of abusive, traumatic services become a norm in the country. So none of this is accident. It's sort of a setting that promotes infectious diseases among people who use drugs. Any thoughts, words of wisdom from your side? And check on your neighbors, because some people are sleeping.
No, I have a more conceptual question.
Sorry?
I have a more conceptual question. Addiction. Like in Mexico, for example, the scientific community uses the NIDA, National Institute of Drug Abuse concept. I'm a historian, so I prepared that Bruce Alexander understanding of addiction. But do you have like a definition of addiction for your program?
Right, so I usually try not to use the word addiction, I use the word dependence. And basically dependence is anything, it's a condition that you develop where use of a particular substance gets in a way with your family, social life, your work. And where you want to stop and you can't on your own. So that's sort of a WHO-ish definition of addiction, of dependence. And so, it's helpful to me because who am I to judge someone's drug use? I don't know, someone smokes every day at night to help them sleep. It doesn't interfere with their schoolwork, it doesn't interfere with their family relationships, their girlfriend. Who am I to say that they're dependent? But if the person says, it's getting too much, I wake up in the morning and I'm a little off, I should do something about that. Yeah, maybe seek some help. But I think it's a good question because parameters of how we define addiction are incredibly important because then based on that, we put services in place or not for people who need them. So HIV epidemic among drug users for me is a perfect classic example of how criminal justice approach overtaking as a priority in a national strategy creates awful, awful outcomes. And that is one of them. So, in earlier session, there was a mention of overdose in the United States. So let's take a look at this. I mean, I actually, when I think about US and the overdose crisis, I mean, this is like a perfect storm. I don't know if you know this term, perfect storm. It's basically all of the conditions came together to create this enormous storm, and that is what happened in the United States. And it is about everything that US does wrong. I mean, really, everything. The criminalization of people, the 500,000 people who are in American prisons, lack of good treatment services, lack of health insurance, lack of harm reduction services for most part, pharmaceutical greed. I mean, it brings everything to create this overdose. Poverty in many communities. Basically, for me, overdose crisis in the US is an example of structural crisis that created this awful outcome of 72,000 people dead. And now it's actually really interesting because if you look at, when you look at solutions, there is no recognition that this is a major structural issue. Congress very recently passed a law that Trump is very proud of because they're responding to opioid crisis. More treatment. Okay, great, but it's more treatment that's not necessarily effective treatment. We repeatedly hear how replacement therapy is the most successful replacement therapy for people who are opioid addicted. Now, you look at Florida and those for-profit centers that were created for people who are in treatment, and it is just a horror. There's now money flowing from the government pipeline for treatment. So terrible addiction treatments are being established with no medicine, no follow-up. People are getting rich, and treatment that they're offering is crappy. So there is, a big lesson learned here, other than don't create a perfect storm, is once you do, then let's start thinking about how to deal with it in a similar way. So it is about economics, and it is about making sure that people have access and insurance, and that they have someone to leave their children with if they are going to a 2-month center in Florida. And so, a list of questions is really, really long. And, I would say, if I were to make a list of, what is needed, probably 40 points. The law that was passed addressed maybe 3. So is it going to help some people? Yes, it's going to help some people. But before we actually see this stabilizing and going down, I think it will take a while. 72,000 people died of overdose last year. That is more than at the worst moment of AIDS crisis in the US. These are shocking numbers. And all we know how to do, send them to treatment.
I was just doing the numbers on those 72,000 deaths. That's about 22.1 death toll per 100,000, which is pretty high. Not even the homicide rate in the United States is about 10 or 9. So that doubles the homicide rate.
Yep.
So it's I think it's a very important issue, meaning that it's more important than homicide.
Yep. So I don't want to say what's more important, maybe, but I want to say that this is, these are some serious structural problems that created this situation. And of course, fentanyl, now on top of it, right? Coming, as you said, from Mexico or China or anywhere else, however the US wants to create that picture, is only making it significantly worse.
Ahí se consideran las muertes por sobredosis por opiáceos recetadas por los médicos.
¿Puedes repetir para que atrás oigan?
Que si En la presentación solo se consideraban las muertes por drogas ilícitas o, bueno, entonces eso nos podría estar hablando de la crisis actual de las prescripciones de opiáceos legales en Estados Unidos.
So no, this is overdose.
Esto es de sobredosis.
Okay.
Pero sobredosis por opiáceos legales.
Overdose of opium.
Okay, so here's why I won't tell you that it's overdose, that it's opium.
No te voy a decir que es overdose, te voy a explicar por qué.
Because very rarely will someone use just opium.
Raramente vemos a un usuario nada más de opium.
Very often when overdose happens, it's opioids and Xanax and alcohol. So when you have people when you have people who passed away tested, it turns out that there are multiple things in their system. We often call them opioid overdose, which I think is very accurate. Because the amount of opioids that was taken was just not enough to kill anyone. But because it was alcohol and because it was benzos together, that's what basically caused the overdose. Any other questions? No? And I hope to be wrong. I really, honestly, from the bottom of my heart, hope to be wrong. And maybe introducing one thing or two things is going to make a major difference. But I fear that we really have created a mega perfect storm that we now are going to be undoing for years to come.
¿Cuál ha sido el papel de la sociedad civil y de las organizaciones de consumidores en presionar la incorporación de medidas de reducción de daños como la naloxona o los medicamentos o salas de inyección? ¿Sí se ha podido avanzar en algo?
Well, right, so what has been the role? I'm a big fan of civil society. So I will tell you that they're trying as hard as they can in the current environment. Can they do more? Who knows? I mean, naloxone distribution is now actually a pretty prominent part of interventions in the US, and that includes availability, wide availability in pharmacies, and it includes Good Samaritan laws that if I call for overdose of someone who is taking drugs with me, the police is not going to ask me about my drug taking. But safe injecting facilities still are no-go in the US, and not only are they a no-go, federal government basically says that they will go after anyone who opens one. And that is a very serious threat, and here's why. Because there's something that is called crack laws in the United States. You may remember crack epidemic, right? Epidemic. And as a result of crack epidemic, laws were passed that if you are allowing someone to use drugs in your environment, the police will come and seize the building in which that happened. So imagine being a small civil society organization that wants to open a safe injecting facility. And that is a law that's being quoted as the one that they will basically take away all your assets.
Kasia, you were talking about a perfect storm at the beginning. I see that the progression in that statistics, it's pretty like arithmetic until 2012, 13, and after that it used to hike very fast.
Well, I'm not an expert on the sort of pharmaceutical issues, but I think this roughly is the time where opioids were very pushed by pharma and very widely available, much more so than needed. And so the problem that we created with that is that once this was noticed and doctors started to cut people off, then many people were in fact dependent. And so then they started relying on the illicit market. And in that illicit market, we had fentanyl. So again, really, if you wanted to design a tragedy where 72,000 Americans would die, perfect. Everything went wrong. Okay, so harm reduction. Working with people who are drug using in a way that is not offensive, in a way that is inclusive, in a way that meets the client where the client is. So, this is about, so when we talk about, instead of criminal justice, public health, this is what we mean. So compassionate, pragmatic, individualized, empowered. You're not a loser. I'm not going to tell you what to do with your life. We'll work together to see what can be done to help you deal with the problem. Alternative to moral and criminal models. A lot of church-run centers across Latin America. Moralizing, praying people out of their dependence. It works for a tiny percentage, but does not work for most. Accept that risk is a part of life, and people are willing to take that risk. So rather than punishing you for it, let's see whether we can reduce that risk. So if someone is injecting and is not ready to stop, okay, what can we do? How about smoke? In Latin America, there's been discussion about providing cannabis to folks that are addicted to coca paste. That's harm reduction. Okay, if you're not ready to quit entirely, how about smoke a joint to help you fall asleep, right? That's harm reduction. Shift focus from abstinence to reducing drug-related harm. And this is sort of my favorite piece, and I'll tell you why. So as people use illicit substances, they do it for multiple reasons. Shout it out. Why do people do drugs?
Stress.
Okay, stress, to alleviate stress.
For fun.
For fun.
For pleasure.
For pleasure.
Work.
To work.
Curiosity.
Curiosity.
Anxiety.
Anxiety.
Pace.
Pain management. Yeah? Yes, to forget. Oh, right. Okay, so complex reasons why people use drugs, right? Those folks that use drugs for sort of as self-medication, as relief of pain, are most likely to become dependent. And you cannot see it anywhere more clearly than with women. So I visited multiple drug treatment centers for women who were heavily dependent. And systemically, and it doesn't matter whether it's in Colombia or in China or in my own country or in Malaysia, the story is the same. History of violence, abuse, neglect, and when all of that gets too much to bear, many women turn to self-medication. And what may happen for some of them, dependence follows. Particularly if there isn't harm reduction, if there isn't someone that can help them, somewhere in between, step in and actually be helpful. And so, imagine living a life where you know that drug dependence is basically becoming a huge issue. Now imagine if you're a woman that is from a sort of, imagine a woman who is taking care of her parents, has 2 kids, is a single parent. How is she going to go to drug treatment? Right? So imagine when someone actually realizes that there is a problem, is able to somehow manage the complexity of life, children and parents and partner and everything else, and actually step out of her life and go into treatment. And the treatment, as it often is not of great quality. Because again, often these are poor women, rely on public assistance, not great treatment. And then she fails. And then she is required to live in abstinence. And she fails. Okay, you know what happens? Here's another example of why she's a loser. Here's another failure. And I hate, and you can see me getting emotional, because I think it's such a setup, particularly for women, but for everyone. And that's why really any positive change, baby steps, helping people to go into outpatient, all of that, come to harm reduction services just to have a cup of tea. If you're not an injector and you don't need needles, you don't need needles. Come to just develop a relationship with a person who is friendly and is not going to tell you that you're a loser or a failure. Because those baby steps actually get you forward to where you need to go. And that is why, interestingly, Safe Injecting Facility in Vancouver has a detox upstairs. And we often hear, drug users, here active drug users, and here people in abstinence, and you have to keep them apart from each other. Vancouver shows that's true. People come to Safe Injecting Facility. They come to shoot. They come with the drugs, they shoot heroin. Sometimes in their neck, in their groin. It's all really complicated to watch. But when someone comes for the 50th time and 100th time, and everyone knows your name, and everyone asks if you need a sample, and if you need to sit, and maybe you need help with social services, you develop that sort of a relationship. The moment when you feel like I'm done with using, they say, okay, just go upstairs. You don't have to sign up and wait for 3 months or wait for a week, or here you go. You go immediately. If there are no beds, they'll find you a bed somewhere else. But once you enter into that space, take care of it. They will take care of it. So abstinence is an incredibly complicated and harsh goal. And if you look at what happens to people, I have a number of people who are now sober, who have been through 7, 10, 20 treatments. And sometimes each of them move them a little bit more forward towards sobriety. But some of them traumatize them more than the traumas that they had in childhood. 2 people have
Buenas tardes. En relación ¿escuchan?
Sí.
En relación al tema de las mujeres, se sabe que hay más criminalización y estigma, tal vez doble o triple, por cuestiones sociales y culturales. No sé si nos podría hablar un poco sobre el tema de mujeres usuarias que son madres, o algún tratamiento que sea por parte de la rehabilitación.
Okay.
The experience with drug show us that a lot of treatments replicate domestic violence between the users and the family. And how adoption treatments provides alternative of replicate violence in the community of the users.
Yeah, so here's women and here is violence in communities, yes? And the third one, also on treatment?
También sobre
Yeah, well, about.
Sorry, I don't know if you're going to touch on this after, but I'm thinking about children, and according to the human rights theory, the state has a reward duty of care. And how does this apply in the harmonization of cuidado?
Okay, so violence in drug users communities and treatment, women, children. Okay. So let me start here. I actually think that one way to deal with violence is actually to, if there's a harm reduction service available, that is the way to get at it. Because here drug users actually, with support of professionals or semi-professionals, are able to develop their own community norms. And I would say that that is one way to address the problem. It's never to bring in criminal justice into the outlet. But you know, I have a colleague in New Jersey. There's an organization that, if you look at Help Not Handcuffed, he says that his worst trauma was in drug treatment facilities. But again, you know, I think because they happen under the umbrella of drug treatment should hurt. There's something wrong with you and it should hurt. And if that's how we think, you know, some violence in treatment facilities is not going to bother anyone. So on women. So I think, you know, when it comes to treatment for women, I would say on demand, as close to home as possible, as flexible as possible, and if possible, for women only. So you will see that very often harm reduction services will have hours just for women. You will see that drug treatment facilities actually accommodate, you know, you can come in immediately after you drop off your kid at school at 8, and you go to home at 2:30, because that's when your child comes from school. So, you know, sort of facilities that make you come in from 9 to 5, and then tell you that you're not compliant when you go, pointless.
And what about pregnancy?
You know, I would say that if someone is opioid addicted and pregnant, my first response would be to see whether they need methadone. You know, I mean, this is a really important point to keep in mind, and it's very counterintuitive for people. Because, you know, often you think, okay, you're pregnant, you should stop using drugs. That may actually be the worst thing you can do. Because if your body is literally physically dependent on a substance, then just stopping it is really not a good idea. So again, sort of use harm reduction principle to help the person reduce their drug use slowly. Maybe you know, again, don't shoot, smoke. Maybe start, see what cannabis does for you. Maybe very slow tapering off of heroin is a good idea. But you know, I would say that nothing is worse than being on the streets and hustling for drugs. If we can help, you know, if we can help limit that or reduce it ideally, that's the greatest thing. Everything else we can work with after the baby is born. Now, you know, it's interesting because, well, then the baby is going to be born and they yeah. You know, but there is a protocol. It takes maybe 3 weeks to a month where you slowly, right, reduce intake of an opioid. That the baby might be getting tiny amounts. And there are plenty of studies that show that it's not the drug that harms the fetus, it's the lifestyle that harms the fetus. So if you have no food, no prenatal care, you know, if you have to hustle for drugs, sell sex, your partner beats you, all of those things are bad for the fetus. Drugs is the smallest problem there is. But often, you know, it's sort of mind-blowing. People just think you should just stop. Well, sometimes you should stop if you can, of course. But often you can't. And children. Well, okay, so the state has responsibility to take care of the child. That is all the state has responsibility to do, right? No one says state has responsibility to take away that child. And I think the problem is that we interpret state having responsibility to care for a child equals take it away from the mother. And I mean, we see that a lot in the US, right? Where women are drug tested during childbirth. I mean, imagine the craziness. And then the kid is taken away and the mother was jailed. That's a severe over-interpretation of the state's responsibility. So again, like in any other situation, what social services can we put in place? Can we make drug treatments available? Good quality drug treatment? Can we make sure there's food and prenatal care? What is it we can do to support that mom? You know, taking away a baby is the most dramatic and drastic thing you can do. And you know, for most part, where is that baby gonna land? You know, often in foster care, where, you know, sometimes it's great, sometimes it's awful.
But I'm sorry, I didn't mean that. Actually, I meant, what can you do to reduce harm among children? Children who are drug users, like teenagers, like...
Well, good quality treatment. I mean, I would say good quality treatment, but really we have to insist on good quality treatment. Also, you know, again, it's sort of a complicated process, but you have situations where harm reduction services do not ask kids, people how old they are. Because they don't want to know. Because they still think that a 13-year-old that comes every day for his cup of hot soup and is in contact with someone is better than a runaway that is going to just disappear. So often harm reduction, low threshold services will just not ask how old. Because once they know, then there's a whole slew of actions that they have to take. Okay, last question because I have nothing to say.
Con respecto al tema de los niños, yo quisiera agregar que muchas veces lo que ocurre es que a los niños no se les empieza a hacer la evaluación de qué tipo de consumo hay, sino que rápidamente identificamos que está consumiendo y de una catalogamos, no, ya va a ser un adicto, va a tener una dependencia, y muchas veces lo que hacemos es cerrar una puerta. O sea, no hay posibilidad de diálogo, de entender qué está ocurriendo con él. Nosotros acá tenemos un programa de intercambio de jeringas, hemos tenido menores de edad, o sea, chicos de menos de 18 años que están inyectándose heroína. ¿Qué hacemos? Indagar. Él va y nos pide jeringas, le damos jeringas. Sí, nosotros no damos la sustancia, valga la aclaración, la heroína en Colombia es ilegal. Pero ¿qué ocurre?
¿Qué es legal en Colombia?
La heroína es ilegal. Pero ¿qué ocurre? Si hay alguien que ya está consumiendo, lo mínimo que necesita es una atención y que se le pueda orientar. Entonces nosotros le brindamos eso, pero primero indagamos pues realmente cuál es el tipo de consumo, cuáles son esos hábitos de consumo, cómo lo hace, cuándo lo hace, quién siente, porque hay muchas otras variables ahí. Y tenía una inquietud y es, ¿dónde encuentro ese protocolo de tratamiento para los bebés con las mamás embarazadas?
I'll send it to you.
Te lo mando.
So, you know, one thing that you can do yourself is look up an organization which is called National Advocates for Pregnant Women.
Esa organización, National Advocates for Pregnant Women.
And they have a lot of resources.
Tienen muchos recursos.
And actually, they may have some in Spanish
Creo que
because
es en español.
they work. Yeah, because they may actually have, translation of this. So. Okay, so let's go down the list.
Veamos la lista.
So shift the focus from abstinence to reducing harm, harmful consequences, and sort of recognize that harmful consequences are a continuum. So you're just basically moving people away from the most harmful drugs and administration to as less harmful as it is possible, rather than abstinence. So when you think about two parts of the world where drug control went up very fast. On the Afghan border, Central Asian countries, Tajikistan and Kyrgyzstan, for centuries, and in India, where there were opium dens for many, many years. People were using opium tea, they were smoking opium. Right, those countries, former Soviet Union, Central Asia, and India, and also Pakistan. Did people get in trouble with opium? Probably. Just like they do with booze. Okay, but there were no dramatic health consequences. On the whole, here's what happens. The United States engages with drug control in Central Asia, on the border with Afghanistan. Within 2 years, from zero HIV to very high HIV infection rates. Why? Because people stopped smoking opium. Right? I mean, you can smell it. It's sort of a tea shops that were selling sort of civilized way to have opium tea all closed. Those that were truly dependent started injecting heroin because that was the only thing that was available. HIV followed. So this is an example of anti-harm reduction. This is where criminal justice and law enforcement basically causes public health crisis. Same thing in India, in Mumbai. Opium dens were actually something that was in existence not that long ago. And then drug control became a major issue. All of those opium dens got shut down. Again, those people that were dependent turned to something else. Right? So all of those are examples of sort of anti-harm reduction. So again, small incremental positive steps are considered success. Abstinence may be the best outcome for many, but not I'm not going to say that word, but not a must. Start where people are, low threshold, challenge stigmatization of drug use and drug users, understand them within their frame of reference, not your own, build on people's strengths, and collaborate on setting up treatment. And you leave treatment, not for you, you didn't fail treatment. Okay, you gave it a try. And back to a harm reduction program. Without shame, without feeling traumatized. Okay, so now a couple of countries that did it well, or that do it well. Now here's what I want you to keep in mind. I really know that Latin America has its own specificities. So I'm not encouraging you to copy Switzerland or Portugal or Holland. Okay. I just want to explain justification that they went through to develop the strategies that they have. What I really would hope is that 5 years from now, I'm going to either replace those best practices with Latin American countries, explaining to Asians why you did what you do. Okay? So please don't, I know that the situation is different. But in all of those countries, situation was also a little different. And they came up with a solution that works for them. So I want to go through them quickly, just so you sort of get my point. So Switzerland, very quickly. Late 80s, very prohibitionist country, a large open drug scene in Zurich and few other cities. You know, in the parks, people injecting. So here you have, you know, fancy banks with, you know, a lot of international money, and outside in the parks, here's what happens. So large open scenes. So here's what happened. One of the people that actually Diego and I have a bit of a relationship with, good drivers, was the president of Switzerland, where a lot of those changes taking place. They actually went to the injecting, to all those parks. Governments, nurses, doctors started going and talking to people. And asking, you know, what is it that you need? Again, this happens in a context of very punitive policy. And so those folks that started going to and talking to people in those parks were asked, right? So what is it that is needed? They were given a voice in public policy space. And what ended up happening there, again, when Ruth was the president, is that they developed something that is called 4-pillar policy. Prevention, treatment, harm reduction, law enforcement. Now, many of you will look at it and say, all of our countries have 4 pillars. And you're probably right. Now, this was many, many years ago. And if you look at the budget, and this is the key, all of those pillars are well funded. Okay. I think for most countries, if you tell me that in your country there are 4 pillars, okay, if you tell me that there are 4 pillars, what I will tell you is that it's very likely that one pillar is very well funded. Which one do you think it is? Law enforcement. And everything else is a toothpick. And that is mostly, maybe prevention is a thicker toothpick. So the magic of Switzerland is that they actually funded everything. I don't want to say equitably because the sort of the needs are slightly different, but everyone got funded very well. So here's what ended up happening. Rapid increase in access to low threshold substitution treatment. So out of those folks that you saw in the park, 18,000 out of 25. Just think about it. 18,000 out of 25 are in methadone treatment. That is mind-boggling. That they were able to go up this fast and offer treatment to people. And then those that didn't do well on methadone treatment, because they just didn't do well. They were offered heroin treatment. Again, with the assumption that it's better that you get free heroin from the government in a clean setting than you hustle on the street. So roughly 2,000 people, somewhere between 2 and 3, are in heroin maintenance programs. Oh, by the way, this is an injecting facility. So you get your heroin, I see you, get your heroin and go and inject. Okay, so you have this, as opposed to the part that you saw before. So actually, Switzerland has the highest rate of people in treatment. I mean, people who need treatment in treatment. So that is sort of their revolution. And you know, again, this is very Swiss. I mean, no one has any doubt that this is very Swiss. So, what I really hope for every single of your countries, come up with a solution that works for you. But you know, in a country that was very conservative, and still is politically very conservative, and in a country that was very conservative punitive when it comes to drugs, this was a huge decision that they took. Bring everyone inside and offer them what it is that they need. Okay, we have a question here, someone, here, and on top.
So where did the Swiss government obtain? Where did the Swiss government obtain the heroin?
From pharmaceutical companies. I mean, the Swiss pharma supplies them with heroin. Clean, you know, purity, you know, no one overdoses. Yes.
Thank you for everything. Actually, I'm gonna have to teach tomorrow, and I think I have getting almost half your slides. But I think also one point.
It's nice.
I know, good minds. I'm gonna have to do a quiz about this tomorrow. But I think maybe if you could emphasize that, you know, it didn't happen from overnight. Like the Swiss government also tried for many years to clean out the streets, time and time again, until realized that it was not a viable solution.
Right, so when thank you for that. So when I say punitive drug policy, I mean punitive drug policy. So there weren't any efforts to lock people up and so on, and all of them. I mean, what did happen as a result of cleaning the streets is that it actually pushed people into those spaces, into those parks. So that is a Swiss solution to the problem. Now, I want you to hear me well, because people sometimes somehow manage to understand me, and though I'm saying that out of 25,000 people, 20,000 are on heroin maintenance. No, 18 are on, I mean, at that time, 18,000 were on methadone, and those that didn't do well went on to be on heroin. So, yeah, so here's what happened with new HIV. Nicely, new rates of new infections went down. Look at what happened to the criminality among people who use drugs. Because very often people will tell me that's not convincing to me, right? Because they're criminals. And you know, this is not rocket science. If a person is an active drug user and needs to hustle for the drug and is truly dependent on the drug, of course there's going to be a significant sort of criminal. Yeah. Yeah, there will be some criminal offenses. Cars stolen and so on and so on. Because you're dependent or you have it. No, you don't. Because you get it free. So just one point, just because I like that point. Because it shows how we don't know much and sort of make policy from assumptions. So one of the biggest criticisms of this was that once you give heroin users free heroin, then what will happen? What do you think will happen? What's your fantasy? No, they can't really sell it. They can't sell it because they have to inject it in the clinic.
Consumption will rise.
Yeah, consumption will rise. Come on. More fantasies. I'm sure you have more.
No more peddling or trafficking.
Well, here's what many people thought. If you give heroin addicts heroin, there will be no limit. It'll just, I mean, the dose is going to grow and grow and grow and grow forever. Not true. People stabilize on what their dose was, and get this, started coming down. Because you know what? If you are a drug user that is committed to a drug user style, who wants to go into that clinic twice a day? Sterile clinics, with a nurse watching you. You want to go, now you have all this free time. You have maybe some counseling sessions. You now maybe have a relationship. And maybe you now are talking to your parents. Maybe you want to go back to school. Who wants to go? Have this sort of be on a leash in that way. What if you want to travel? What if you want to go to Italy and see Venice? So basically what ended up happening is people started to reduce. And that was like the biggest wow, because none of the researchers predicted that happening. Everyone's assumption was, what are we going to do when someone doubles or triples their dose? Did not happen at all. So it sort of shows you, how little we know and how we just function on assumptions. Yes.
Teniendo en cuenta que en Suiza es legal la heroína, yo me pregunto, ahorita que pusiste el ejemplo de que alguien va a Italia, alguien viaja, ¿cómo respalda Suiza a la persona que va a salir del país y pues que no en los otros países es legal el consumo de heroína? ¿Cómo?
Exactly. I mean, that is exactly why people sell heroin. So if you are on heroin treatment, you can't take it out of the country. So maybe you would try to go on methadone if you go outside. Right? Or get a prescription for another country, depending where you travel. So just one last thing about heroin. When I was in Zurich, sort of touring various folks that were responsible for various parts of drugs portfolio, I actually wasn't planning to go to heroin maintenance program. And because, I sort of felt like it's a little bit like you're staring at people. Like, I believe you, there's heroin, people will shoot, I feel like I want to go and watch. And so the head of police in Switzerland says to me, are you going to the heroin program? I said, I'm not.
diciendo que no,
He got me in a car, police car, and went with me because he wanted me to see
él
it.
quería que yo lo viera.
Because for him, it's the most genius thing that his government has done
La
to
cosa
help
más
the
genial que
police.
su gobierno ha hecho para ayudar a la policía.
He said, I can't tell you how many less thefts,
¿Cuánto ha bajado el robo? Hay
hassles
mucho
on the
menos robo,
street,
menos prostitutos en las calles.
and also our heroin market shrunk.
Nuestro mercado de heroína se
Public health system basically did my job.
de salud pública hizo mi trabajo.
Because if you take out of
Porque
circulation
si tú sacas
those
de
heroin
circulación
users
a
that
los
are
usuarios
truly
de heroína,
dependent,
que son verdaderos dependientes de
they are the ones that are using the most because
los
they
que
need
están
it most.
consumiendo más, porque son quienes más lo necesitan.
And so basically it was actually the cop, the Swiss cop that took me to
Fue la policía que me llevó a ese programa de dependientes de heroína.
Okay, so I want to just check the temperature in the room.
¿Cómo vamos?
What time is it?
¿Qué horas son?
7:24.
Okay, are you okay to
¿Vamos bien?
continue going?
Yes.
Okay, Portugal. My other favorite country.
Mi país favorito.
Okay, so one of the highest levels of relative poverty in the European Union. You might know that Portugal was the last one to enter EU before the expansion that took place later. High level of imprisonment,
Alto nivel de encarcelamiento.
historically low levels of illicit drug use, high levels of injecting drugs and overdose deaths and HIV, and 57 increase in drug-related deaths between 97 and 99. So, you know, a country of 10 million people, very Catholic, very conservative, with a drug problem. And so they started to notice that, you know, sort of when you sat at a dinner table, everyone had a story about, you know, cousins, friends. Drugs started to be an issue. And there's also colonial history that contributes to that a bit, but yeah, but that basically, that was the end of the 90s. So basically, they decided that the way they will address the problem is to decriminalize personal possession. And the ideas behind decrim to reduce harm, to stop senseless punishment, and to better control the drug issue. And look, new strategy. Also for pillars. Prevention, harm reduction, expansion of treatment, and social reintegration. Now, we talk a lot about decrim in Portugal, but this is actually quite interesting. Because the government actually earmarked a significant amount of money to help people sort of reintegrate. So drug treatment people were responsible for helping people find jobs. And they had a budget that if you hired someone that just came out of drug treatment, they would give you a year worth of salary for that person. Because their idea was having people stop and not go to jail, not good enough. They need to also find a job. And so this is how Portugal addressed its problem. They also developed something that is called a threshold table. And their threshold table is roughly 10 days of use. So if you are stopped by the police with 25 grams of cannabis, 5 of hashish, 2 of cocaine, grams of heroin, 10 pills of ecstasy, no criminal sanctions. If you want to argue with those quantities for 10 days, that's okay. I know the average quantities. And so that was that's what they managed to that was the sort of innovation that they brought into the drug policy field. They created something that is called a dissuasion commission. So if a person gets stopped by the police, the police is gonna, well, if they think it's 10 days of a drug, it just gets thrown out. If there is a little bit of a question, they'll take it and then you will receive a letter inviting you to come to a dissuasion committee. And the spirit of that dissuasion committee is, what's happening? Why are you doing drugs out on the street? Why did you get stopped by cops? Do you need treatment? Is there something that you think we can help you with? How is your relationship with your family? Are you in school? Are you working? So basically they try to assess your needs. And if they think you need treatment, they will encourage you to go to treatment. Now life gets more complicated when you get stopped 2 times, 3 times, 4 times. Because it does sort of raise a question, why? Like, why do you need to be out in public doing this? And maybe you indeed do need treatment. Or if you have no need to, comply with the law, and you're basically defiant and smoke in the open, then you could get a fine. So basically, that is their sort of idea of dealing with drugs. Now, here's why I want you to sort of take it with a grain of salt. Again, this happened 20 years ago, just like Switzerland. So many people argue that dissuasion commission, it's still a little too controlling. But I think it's important to put it in perspective historically, because when they were doing it, they really were pioneers of drug policy reform. With a lot of criticism, INCB, other European countries were looking at them, International Narcotic Control Board. And so again, this was a process of negotiation between various parts of the government and prisons and police and health, and this is what they came up with as a solution for them. Expansion and treatment. Very often people felt like, well, if there's no sanction, why would I go into treatment? Again, wrong. They actually expanded a number of available treatment slots, and look, the numbers of people in treatment went up. And each country, when you sort of look at its story, shows you how, we often make policy based on assumptions. Once you provide free heroin, people are just gonna, the doses are gonna skyrocket. Once there's no punishment, no one is gonna go to treatment. None of that is true. And so that's why, if you think about solutions for your own community, for your own country, do not just take off the table ideas that some people may think are crazy. Because look, those crazy ideas work. They just have to be given a chance. And I think when it comes to drugs, we have a very narrow window of what we're willing to do. Okay, so again, HIV, HIV infection rates down. I missed one slide. Okay, so the basically reduced burden of drug offenses in criminal justice system, that's no surprise.
No es sorpresa que se redujo.
Reduction in prevalence of injection drug use.
También se redujo la prevalencia.
Number of overdoses fell almost by half.
La cifra de sobredosis bajó casi la mitad.
Increased amounts of drugs seized by the law enforcement.
Aumento en la cantidad de drogas
And actually reduced drug use among adolescents.
se redujo el consumo de drogas entre adolescentes, de drogas ilegales.
Okay, any quick thoughts about that? And then we go to Holland.
Comentar algo al respecto, tienen alguna creo que sí, si no, nos vamos a
I have a question related to the consumption in prisons. I don't know if these countries make some kind of program related to consumption in prison, because it's also a hotspot of drug consumption.
Drug consumption
In prisons.
or in prison? In Portugal?
In these countries, or do you have an idea if there is a kind of program related to drug consumption in
Anywhere.
prison?
So there is actually, Germany has needle exchange in prison.
Bueno, Alemania tiene intercambio de agujas en prisionales.
I think the countries that have managed to deal somehow with drug consumption in prison are those that acknowledge that it exists,
De drogas y de consumo de drogas en
rather than pretend that it doesn't exist, and offer services the same way as they are offered outside. Whether it's methadone or other forms of treatment, or some countries in Europe, Spain, Germany, a couple of others, actually offer needle exchange programs.
Just to share, I work as a psychologist in a prison, and I try to implement one program of harm reduction, but the director, they didn't want it, because if I have a program of harm reduction, then I'll be saying that there is drug in prison, there shouldn't be, so it's really hard, at least in Brazil it is. No, there's no drugs.
I think that's the usual answer. Okay, so on to Holland. So here's some background. What they really got at in the discussions and preparations for the changes in their law is that there is acceptable risk and unacceptable risk when it comes to drug use. And so they basically decided that cannabis is acceptable risk and other drugs are unacceptable. That was their calculus, that was their decision making. Also, assumption that giving young people criminal records, not a good idea. And in that spirit, in 2080, first coffee shops opened in Amsterdam, Rotterdam. So that's well over 30 years now, close to 40 years ago. And that was their proposal. Safe-injecting facilities and white methadone Switzerland. Declaim, dissuasion commissions, Portugal. Coffee shops, Holland. How many people have been to a coffee shop in Amsterdam? Okay, so what you may not know is that owners of coffee shops buy from illegal dealers. So it's actually, and again, now look, this is 1980. They were complete mavericks. And they were really afraid that the international drug control is going to go after them. So they basically said that coffee shops are like little magic places where illegal cannabis, once it enters, becomes legal for the consumer. And this is how they dealt with the international drug control issue. Now there are discussions about how to change that and how to grow and purchase locally. Now, here's the problem, or maybe differently. What do you think would be a problem with that approach in Holland? So actually, users are not all that happy about this idea.
Indeed, local produce would be more expensive than maybe the ones.
Okay, so the key here is locally produced.
Yeah, it would be more expensive.
How? Yeah, but how are you going to buy Afghan hashish? And how are you going to buy Moroccan something else? They're so used to the variety that they don't want just that stuff. And that's what becomes a problem. And you know, it's a little bit of an issue of how this is going to happen. But the discussions are underway right now. For everyone else outside of the cannabis users, low threshold services, consumption rooms, needle exchange programs, and as you can see, virtually eliminated injecting drug use and lowest rate of problem drug use in Europe. Again, like in the other cases, the assumption goes, if people can use legally, they will just be stoned all the time. Right? That was the fear. That was what everyone was saying. You look at number of problematic drug users in Holland, very low. Also, if you look at all of the neighboring countries, Italy, Germany, Belgium, France, yeah, you know, all the neighboring countries, you can't quite see them up. Actually, their drug use is relatively low. I think it's because it became normalized. So the problem that they do have is now that there are no borders, is, you know, in border towns, German kids, driving in, buying pot, driving out. So the traffic that is now, that has now accumulated in border towns, that is a problem. Because kids from those other countries want their cannabis, but not because Holland has a cannabis problem. So actually someone petitioned that they should open cannabis shops in those places where they used to have border control. Because they're right on the border, and they can just get their pot and leave, and they don't have to enter the town. But as you can imagine, that would be a little bit of a nightmare for international relations. So basically, I will end here. Okay, in terms of arrests. Okay, coffee shops generate about 400 million euro. So that's a pretty significant sort of contribution to the local economy, and that's why there was an idea. Because there was an idea that maybe only Dutch users with a card will be able to shop for cannabis. And mayors of biggest cities said no thanks, because this generates significant revenue for us. And so actually local governments were in opposition to that idea, other than border cities, because as I said, they really have a problem. So lighter enforcement did not lead to more drug use. And this is just to give you a sense. So this, you know, this is Holland in terms of use between 25 and 15 and 24, and this is their drug use. With coffee shops legally. So what really sort of makes me excited for all of those examples is that all of the fears and assumptions that policymakers have are not true. And you know, and this is a part of the problem with drug policy. Because they will tell you, Evidence.
políticas.
Well, how do you get evidence if it's not allowed?
Bueno, ¿cómo vas a tener evidencia si no te lo permiten?
So for those of you who are scientists,
Para los
you should have noticed that here
noten que aquí
the years are different.
los años son diferentes.
And I promise you, I didn't pick the
Les
years
prometo, yo no
just to create that table. Okay, this is how it was reported to EMCCDA. This was the, I should update those numbers, obviously. Jean-Paul Grund, whom some of you might know from Holland. This comes from his report. We should update them because that's the latest he was able to print out from EMCCDA. Okay, so I end here again with encouragement to do not dismiss ideas that seem wild. Because you know what? All of those ideas were wild at the time. And there are definite leaders in drug policy reform. And so I would love to have 3 of those examples from We have one, Bolivia, Coca. We have Uruguay, let's wait for the data. Yeah.
Esperemos todavía los datos. Hay que esperar por los datos.
Yeah, we're
Brazos abiertos, Brasil.
Yeah, right. But I mean, it's good to have a sustained program that actually exists.
Un programa sustentable.
So as you noticed, all of those are national programs that actually are
nacionales.
So I really hope that we stay in touch through the various networks.
Seguir en contacto a través de todas estas redes.
And we really need new leaders in the field.
Necesitamos nuevos líderes en el campo.
And I hope it's you.
Y espero que sean ustedes.
Thank you very much.
Gracias.
Creo que tenemos espacio para algunas preguntas, no mucho, tal vez 2 o 3 preguntas. Por favor, esperen a que llegue el micrófono para que todos podamos oír.
So I wanted to know what are the characteristics of well-run rehab centers?
Rehab center?
Yeah, what makes a good rehab center?
Live in rehab center. Yes, a place where you live.
Yes.
Not in our inpatient program.
Yes, inpatient programs. Yes.
Okay, so inpatient program is going to be, first of all, voluntary. Second of all, it will allow access and communication with family members, with others, people that are important to you. It will have a medical staff that will be able to assess you for Hep C, any other medication, and actually provide those medications. And also we'll have a psychiatrist that will evaluate you for depression, anxiety, and allow medicines for that if needed. Limited in duration, so people go 2 months, 3 months, whatever is agreed on, and then midpoint evaluate whether longer time would be useful. And have multiple modes of treatment. So, there are people for whom AA and NA is a great tool.
Hay gente para la que
AA?
AA.
Uh-huh.
Y narcóticos anónimos también son una gran herramienta.
And there are others for whom it's not.
Y a otros para quienes no.
There are people who do really well with individual therapy. And others who have such huge anxiety that being in a group freaks them out. Nothing, if there are activities that are, horseback riding or running or, doing something sort of, volunteering for something local. All of this, happens with respect and is truly voluntary. And people are not forced to do it. and people who actually understand what drug treatment is about. So highly educated, prepared counselors that are there to support you. I think if we start there, we're good. Because, my ultimate goal is that person that comes out of there does not come out further damaged. And if some people actually do recover, that is great.
Well, first of all, I want to thank you for your presentation. It was really good, and it's always really important to, be reminded of the parts of drug policy as it exists right now. I think I really appreciate that you say that it's important to study cases as Switzerland, as Portugal, but also to think locally. And I just think that people working in Latin America are already giving important feedback as of how to improve drug policy. And I think one of the most important learnings from this community is that when thinking about how to reduce the harms of drug policy, you cannot only think of drug users or people who use drugs, but you also have to think about violence and the violence that is the result of drug policies. And I think this is a really important, learning from America. And I think that is something that communities and academics and scholars are already talking about. So thank you so much.
So I want to second that. I think violence is a huge, violence and drug policy are huge. So there's a huge connection. That's not my area of expertise. That's where I think Alejandro talks really well. So, my goal here was to talk about how public health undermines, how drug policy undermines public health. But absolutely, and the entire sort of production, transportation, that is a whole different ballgame. Where again, I don't feel qualified. I think I get it, but I don't feel qualified to lecture.
No, but yeah, I would even say that the homicide rate could even be seen as a public health issue.
Hablando de opciones de tratamiento en diferentes lugares de América Latina, se han empezado a usar plantas de poder y experiencias de cambio espiritual como forma de tratamiento a la adicción. Un grupo indígena de Sonora usa la glándula de una rana para tratar de sacar de la adicción a las metanfetaminas a sus miembros, o por ejemplo el uso de la ayahuasca en Sudamérica como método de tratamiento a la adicción. ¿Sabes de cosas similares en algunas otras partes del mundo, o en el programa han tenido experiencias similares en Asia o en África o en algún otro lugar?
So yes, what can I say to that? So I think generally, whether it's psychedelic drugs, actual drugs like LSD and MDMA, or whether it's plants, I think we have done ourselves a huge disservice for basically making them illegal, because we haven't studied them. So I have no doubt, just sort of logically, that, coca leaves would probably be a great help for someone who is having trouble with stimulants. But we don't know. Ayahuasca, it can be such an intense experience. Again, how do we study? I'm not exactly sure. But I think we now took a break in the scientific world of 50 years of studying MDMA and LSD. We're learning what an incredible benefits both of those drugs have for deep depression, post-traumatic stress disorder. Just imagine how different the world would be for so many people who are struggling with those conditions if we had 50 years of science to back us up. And so I just don't know enough to have an opinion. But should we be open to that possibility? And should we study it as an option? Of course. And I think that the trouble, particularly, I mean, you know, I may not be fair in that assessment. I'm a Polish person who lives in the US, who comes to Latin America, and every time I'm here, I'm sort of blown away. And one thing that I'm blown away by is how disrespected indigenous communities are. So I'm blown away, not in a good way, about how disrespected indigenous communities. I'm sure they have a lot to teach us. And I think we haven't been open to learn and to study and to benefit from it.
La transformación de las políticas públicas también se hace con el lenguaje y con el cambio de términos. Así como ya no hablamos de adicción, sino que hablamos de consumo dependiente o problemático, ¿cuáles serían en este momento como los principales términos o categorías que deberíamos empezar a desmontar o empezar a resignificar en la construcción de un nuevo debate de salud pública en temas de drogas?
You know, I think generally words would sort of, I mean, I don't use the word addiction, and I definitely don't use the word addict, right? I know that saying person dependent on drugs is a little long, but I think that's like a fair and non-judgmental description. So, you know, I think a little bit of discipline as we talk, and just, you know, catch yourself where you feel that, you know, maybe you're I mean, we have that in our own program when we think about people who are growers. You know, we say growers. What is growers? You know, I tell my friends something about growers. They're like, what do you mean? Okay, people who cultivate illicit substances. You know, it's awkward. So, I mean, let's just sort of think about what is a fair description of the program that is not judgmental. You mentioned open arms. You know, I read articles. I actually myself used the word Cracolandia until a friend of mine came back and said, "What is wrong with you? Why would you use the term Cracolandia? You know, it's racist, it's derogatory, it judges people." He gave me a whole list of how that's wrong. You know, people in Brazil were saying Cracolandia, I was saying Cracolandia. So it took someone else to actually say to me, don't use that, that's awful. So I think, you know, if we can just do that to each other and just sort of inspire a discussion that is more open, less judgmental, maybe a little more vulnerable, more honest, I think we'll be in a better place.
Bueno, quería preguntar, ya que nos presentaste algunos modelos de reducción de daño en heroína, ¿qué ejemplo, qué modelo nos podrías hablar de reducción de daño en crack, en cocaína, que es un tema muy fuerte, digamos, en Colombia, el uso del bazuco o el crack?
Right, so I think people who want to stop, I seriously would see whether they would be willing to just smoke cannabis. Right, I mean, I don't know whether you can legally, but I would say that that's harm reduction. Now, the problem with crack is that people often have crack lips when they smoke. very high hepatitis C rates.
Tienen tasas de hepatitis C muy elevadas.
So for example, like Visine,
Por ejemplo,
those sticks,
los palitos Vicin,
vaselina, yeah,
así
yeah.
vaselina.
That's harm reduction because
Eso es
it makes
reducción, porque sus labios están
mouthwash, you know, stimulants dry out your mouth, causing tooth decay.
te seca la boca, hay mucha caries.
So mouthwash, pipes, individual pipes,
individuales,
where you can change the sort of
donde le
the
puedes
last and the
cambiar
filters.
la boquilla y los filtros.
So there are multiple ways we can
Hay
do to
muchas
make sure
maneras
that
en las que te puedes asegurar
less harm happens.
que se dañan menos.
And again, if you think you can encourage people
Y si
from,
piensas que puedes
shifting to
alentar
another drug, or you don't have to shift from one to the other.
no tienes que
Just
cambiar de
reduce
una a otra, por lo menos reducir
and smoke pot in the evening.
y fumar un
Sleeping
churrito
more.
en la noche vas a dormir más.
Nosotros
Food.
tenemos,
All of those
Mira,
things.
todas esas cosas son reducción de daños.
nosotros con una alianza que tenemos con un centro en Bogotá, lo que les da muy bueno, no es un porro para que se fumen, pero sí gotas con extracto de cannabis para que puedan dormir y no salgan a delinquir en la noche. Igual en este momento todavía estamos en un limbo jurídico que esperamos resolver pronto.
So again, these are basic things. Like there's a pretty sort of mean portrayal of people who are crack users. No teeth but all of this is about dry mouth and tooth decay and poor food.
No tienen dientes sucios,
Right. So again, mouthwash. These are basic things we can do to make sure that the harm is
para
reduced as much
asegurarnos
as
que se
possible.
reduce lo más posible el daño. Thank you so much.
Thank you so much. Buenas noches a todos, creo que ya esperándolos.
¿Cómo?
Nos vemos mañana a las 9:30 como que había primero. Y los que tienen aparatos no se vayan.
Sí, traigo. Pero tengo que llevar a...
Entonces es como papelito que uno usa, luego el otro, o
No, you can just say, hey,
I have more scientific, I have not.
Faltan 3 aparatos, por favor, que no se les olvide. Ahí va.